Good afternoon and welcome everybody. I'm Grania Brigden, the Director of the Tuberculosis Department at the International Union Against TB and Lung Disease, also known as the Union. I'd like to welcome you all to this official press conference that will showcase this week's COVID-19 scientific highlights. There was certainly a lot of interest in the COVID-19 and vaccine session yesterday with Dr. Anthony Fauci, and I have no doubt that today's plenary and special sessions looking at the novel coronavirus will also attract as much attention and generate a lot of conversations. We have been very conscious at the Union to promote evolving COVID-19 science this week at our first virtual conference. And I'm delighted to see that we've been able to do that justice with today's official press conference. Before introducing our esteemed guests sitting virtually here with me today, let me run through some housekeeping. This live press conference is being recorded and will be available on the conference YouTube channel shortly after it has ended. Today, we will be hearing brief remarks from all of our speakers, and then I will open it up for questions from our media representatives attending today. To ask a question, please send it via the Q&A function, the question and answer function at the base of your screen, and please indicate your media outlet and who you would like to direct the question to. We will then direct the question to the nominated panelists. If you would like to ask your question verbally, please indicate that too, so we can turn on your microphone. And please try and keep your questions brief. So without further ado, let's begin. Our first speaker today is Dr. Jilian Sachs. Jilian is the head of the pandemic preparedness at the Foundation for Innovative New Diagnostics, also known as FIND, in Geneva, Switzerland. Jilian will talk to the results of a late breaker study entitled Clinical Accuracy, Ease of Use and Limit of Detection of SARS-CoV-2 Antigen Detection Rapid Diagnostic Tests. Over to you, Jilian.
Thank you very much, and thank you to the organizers for the invitation to join this press conference today. As Grania mentioned, I'm Jilian Sachs, head of the Pandemic Preparedness Program at FIND. One of our core work streams at FIND has always been independent evaluations of test performance, also known as testing the tests, for TB, malaria, and other diseases of global health importance. As new diagnostics for COVID-19 were developed, we began research, which is still ongoing, to understand the accuracy of these tests. We've evaluated molecular tests as well as rapid tests for antibodies and antigen detection. Later today, I'll be presenting the findings from a multi-center study on behalf of my collaborating partners from the University Hospital Heidelberg, Charité Hospital Berlin, the Federal University of Rio de Janeiro, and the Liverpool School of Tropical Medicine. We assessed newly emerging rapid tests that detect SARS-CoV-2 viral antigens, which are shed during active infection. These antigen rapid tests are relatively simple to perform that can be used at the point of care, meaning they can be conducted without lab facilities, using an upper respiratory swab that is collected by a trained healthcare worker. We evaluated the tests both in routine clinical diagnosis testing centers in Brazil, Germany, and the UK, and in the laboratory with known quantities of the virus to determine the limits of detection. We are also assessing the ease of use of each test according to the test operator's opinions using a standardized questionnaire. In this study, we present interim results for 6 antigen rapid tests. The clinical performance was evaluated in comparison with molecular or PCR results, the current gold standard test. At the time of the submission of our study, the World Health Organization had a target product profile proposing that antigen rapid tests should be at least 70% sensitive and 97% specific in comparison to PCR. The TPPs have since been updated to state that sensitivity should be at least 80%, and our data show that at least 2 out of the 6 tests evaluated meet these targets. Our data also suggests that the test will have improved accuracy in individuals with higher viral loads, who are those most likely to be infectious and transmit to others. Because of their imperfect specificity, these tests are also likely to be most useful in settings where the COVID-19 positivity rates are higher, to minimize the numbers of false positive tests that are detected. The limits of detection were the same range for all tests, varying about tenfold between assays. Generally, we found the LODs to be higher than those reported by the manufacturers. Finally, the ease of use for the tests ranged from 48 to 86 out of 100 for the first 3 tests that were assessed, with 100 being the most easy to use. Our data therefore demonstrate that although the performance varies across the different brands of antigen rapid tests, some will be accurate enough to offer the potential for simpler, more rapid diagnosis of COVID-19, playing a significant role for public health decision-making globally across high, middle, and lower income countries. One of the tests evaluated has now been approved by the World Health Organization through their emergency use listing procedure, using data from our research study that was included by the manufacturer in the submission package. Thank you very much.
Thank you, Jilian. Our next speaker is Dr. Marco Tovar. Marco is the Medical Director of Partners of Health in Peru. Marco will talk to a very interesting pilot involving the dual test of people for COVID-19 and tuberculosis. This study is also in the late breaker session. Please, Marco, go ahead.
Press. This study was included inside the activities that in Peru we are doing together with some dependents of the Ministry of Health here in the north of Lima. Lima is the capital of Peru. You know, the WHO recommend to screen for these both the diseases, but that was not doing at the beginning of the pandemic, but 2 weeks after the beginning the response in Peru, we began to collect this sputum sample for all the people that were screening by COVID during the visit to the homes, and this is sputum sample that we process for TB, and in the laboratory of Socios en Salud here in Lima and Caraballo, and then in this zone that is in the north of the capital, and this is the result of this study that we obtaining is that most of these people that they refer cough, that this was approximately 25% of the people that they refer symptoms or suspicious symptoms of COVID. 25% of them refer cough as one of the symptoms, and all of these for this 25% obtaining this sputum sample, and from these people, 4 of them person we obtaining a sputum sample from 330 person from a total of 1,300 person. For these 330 person, we had 4 patients with gene expert ultra positive. This is approximately 1.2%. It just means approximately 1,212 case per 100,000 inhabitants. No, that is like 10% more than the national incidence. No, and the principle is that all of these 4 patients with gene expert positive were PCR for SARS-CoV-2 negative. No, if we should not do this screen for TB2, we could lose the opportunity to diagnose these cases of TB. Yeah. And that's what the relevance that to implement this screen for the both diseases now here in this part of Lima, not the zone of Lima, the north of Lima, and now with this previous result, now we have other big activity in all of the capital. Lima have approximately 80% and 9% of the total cases of NDR resistant in Peru, and now we have a lab mobile in a truck with the X-ray there, and we using the artificial intelligence to interpret the X-ray, and now we are discovering more cases during these activities of screening for COVID. No? In this some zones in Peru, like the name Peru is COVID-19 point. It's like it's zones in which the government screen COVID, but we put this activity together of screen TB2. Thank you. I will present more results in this day later and the Jilian level. Thank you again for the invitation.
Thank you, Marco. I look forward to hearing more about the integration of the two tests in screening. Our next two speakers are both participating in the symposium session on COVID-19 and pregnancy and presenting some vital abstracts there. Professor Kristina Adams-Waldorf is the Professor of Obstetrics and Gynecology at the University of Washington. Kristina will talk us through some of the pathogenesis and immunology of COVID-19 in pregnant women in the US state of Washington. Please go ahead, Kristina.
Thank you very much for the invitation to speak at the press conference today. My name is Kristina Adams-Waldorf. I'm a professor at the University of Washington and a member of the Center for Innate Immunity and Immune Diseases and an affiliate member of the Center for Emerging and Reemerging Infectious Diseases. Since the beginning of the COVID-19 pandemic in Washington State, the University of Washington has partnered with 35 hospitals and large clinics across the state that annually capture 61% of the births statewide. We have identified 240 pregnant patients with COVID-19 in Washington state. One of our first objectives was to determine whether specific risk factors are overrepresented within our population. We were concerned specifically regarding obesity because it has been identified as a risk factor for more severe disease in pregnant patients that develop influenza viral infections. We also were interested in type 2 diabetes mellitus, asthma, hypertension, and many other rarer immunologic diseases. What we found is that obesity was overrepresented in the pregnant patients with COVID-19 in Washington state. We found a prevalence of 45% in the 240 patients compared to an overall prevalence in Washington state of 28%. In our study, 70% of our patients were symptomatic and most were identified in the third trimester. In conclusion, we are concerned that obesity represents a significant risk factor for enhanced disease in pregnant patients with COVID-19. There are several reasons we think that this might be going on. Excess adipose tissue can impair the immune response to viral infections, specifically the type 1 interferon response. We're also concerned that obesity can impair pulmonary mechanics and the work of breathing, and together that these two factors can make pregnant patients that are obese prior to pregnancy more symptomatic. Thank you very much for this opportunity.
Thank you, Kristina. Very interesting. Our final speaker today is Assistant Professor Malavika Prabhu. Malavika is the Assistant Professor of Obstetrics and Gynecology at Weill Cornell Medicine in the United States. Malavika's study will be talking about pregnancy and postpartum outcomes of women in New York City. The study has already been fast-tracked to the PubMed.gov site recently due to its findings being so critical, and we feel that it should be seen and heard by a wider audience this time round, especially because it has not received any media attention to date. And I think you will hear that it really does deserve to. Please go ahead, Malavika.
Thank you so much, Grania, and good afternoon, everyone. Thank you so much for the opportunity to be present on this press conference today to discuss our study. My name is Malavika Prabhu, and I'm a high-risk obstetrician at Weill Cornell Medicine in New York City. This past spring, at the height of the pandemic in New York City, we conducted a 3-institution prospective cohort study for 28 consecutive days, enrolling all pregnant women during their delivery hospitalization. Each woman was tested for SARS-CoV-2 upon admission. I wanted to briefly share some highlights from our findings, which will be presented in detail later at the conference. First, of the 675 women who delivered at the peak of the pandemic over those 28 days, 70 or 10.4% of all women were SARS-CoV-2 positive, approximately 80% of whom were actually asymptomatic upon admission. Overall, during the delivery hospitalization, maternal and perinatal outcomes seemed reassuring, with no evidence of vertical transmission, no differences in the prematurity rate, although we did note some increases in cesarean delivery rate among women who were SARS-CoV-2 positive. However, 9 out of the 70 women with COVID-19 experienced at least one postpartum complication, which was 12.9% of all women, far greater than the 4.5% of women who experienced any postpartum complication if they were SARS-CoV-2 negative, suggesting that the postpartum period specifically is a vulnerable time for pregnant women with COVID-19. One additional very intriguing finding is that the placental pathology for women with COVID-19 was notable for significantly increased rates of fetal vascular malperfusion, far above the typical all-comer rate that we would expect. And specifically, this represents thrombotic events occurring on the fetal side of the placenta. This may reflect pregnancy-specific sequelae of COVID-19 associated coagulopathy, but more research is needed. As Grania mentioned, our study has been published in the British Journal of Obstetrics and Gynecology. Our study does answer some important questions, but as with any study, also opens up many more questions regarding the implications of COVID-19 in pregnancy, especially COVID-19 infection remote from delivery, whether COVID-19 is really worse among pregnant women, which has been documented in other studies, why the C-section rate was increased, and whether those placental findings ultimately lead to clinical implications in a larger cohort, all of which are subjects that are forthcoming from our group. Thank you very much for your time, and I look forward to your questions.
Thank you. And as Malavika said, there are many questions. So now we are very happy to be able to take your questions. Just to review how to submit your questions today, to ask a question, please send it via the question and answer function at the bottom of your screen. And please do indicate your media outlet and if you would like to direct your question to any of the panelists in particular, and then we will direct the question to the nominated panelist. If you would like to ask a question verbally, please indicate that too, so we can turn on your microphone. So please keep your question brief, and with that, we will begin. So please do not hesitate to submit any questions. Okay, maybe I will start with a question for Marco. So how do you see the further integration of TB and COVID-19 testing to continue? And then, yeah, so I'll start with that question.
Okay, thank you. I think that in cities in which the prevalence of TB is high, definitely if we don't integrate these two activities, will conduced to not discover all those cases that are now in the community. At the beginning of the pandemic, for example, we discovered most of these people that were doing in the home here in Peru, because all of the people was in the home, and the one in this case they are in the homes really transmit all of the other contact more, because the contact with the relative in their family was increasing. And if we should do this activity to integrate this the screen for both diseases, we probably we will have more cases of TB now from these people in that they share the same house, because the time of the contact obviously increase, and then most of the people in this zone, they can maintain the social distance in the home, because they have a little home different to this zone. I think that this is for the setting with high prevalence of TB, we must begin to integrate these two activities, because these two diseases share similar symptoms, share similar spaces, and I think that is we need to do that.
Thank you. And maybe Jilian, while we're on the topic of detection and tests, it would be great to hear your thoughts on how the role of antigen detection tests and their scale up should the role of these tests and the future use case scenarios for them. Thank you.
Great, thanks so much for the question. So there is currently global guidance from the World Health Organization providing some information on how to appropriately use the antigen RDTs and the settings in which they may be most appropriate given the currently available limited data that we have. So it's expected that antigen RDTs can be used or should be used in settings where nucleic acid testing cannot be guaranteed, or where the turnaround time for the result of that test is so prolonged that the clinical action or public health decision-making would not be effective. In those contexts, we're considering screening individuals who have symptoms who present at healthcare settings, or individuals who have a confirmed epidemiological link, i.e. they're a contact of a known case. Other settings where antigen RDTs may be used is for more broad screening approaches. That would mean testing people who may be asymptomatic and don't have a confirmed epidemiological link to another case. There's very limited to no data for that intended use. And that's where I think a lot of people would actually like to use these tests, is for very frequent screening for broad populations. But I think right now, as I mentioned, given that they have imperfect specificity, we might expect in those contexts to get similar numbers of people who actually have COVID get a positive test to those who do not have COVID and it's a false result. And so in those settings, you might need to have a confirmatory test for all the positives to really be sure that you're diagnosing someone with COVID-19 and can then take appropriate public health measures. Thank you.
Thank you very much. Now, my next question is for Professor Kristina Adams, and this is from Lola Hierro from Alpine newspaper in Spain. So, when you conclude that the proportion of obese pregnant women in Washington state with COVID-19 is overrepresented compared to the state estimates from CDC, do you mean that obese pregnant women are in a higher risk group or are more vulnerable to get COVID-19? Thank you.
Thank you very much for the question. Great question. Again, we began looking at this because of the concern regarding pre-pregnancy obesity, putting pregnant patients at risk for enhanced influenza viral infections, hospitalization and mechanical ventilation, due to the concern that obesity can impact the way that the immune system responds to viral infection, actually impair the response, and also impair possibly pulmonary mechanics, the work of breathing. So when we looked at obesity, we looked at the weight that the woman reported that she was at the beginning of pregnancy, because some of our patients in our study developed COVID-19 already in the first trimester. And this helped to make sure that we were analyzing obesity and the weight of the woman compared to non-pregnant patients. So it's important that we use this pre-pregnancy weight. So when we look at that and we compare women, the weight at the very beginning of the first trimester compared to non-pregnant patients, we saw a very surprising difference, an increase in the prevalence of pre-pregnancy obesity in pregnant patients with COVID-19 compared to what we would have expected in Washington State. And as our study captured such a large percent of pregnant patients in Washington State, this seemed very appropriate to make this comparison. So it's my opinion that pregnant patients that begin pregnancy obese may be at a higher risk for more severe infections with COVID-19. And I think that it's important for all pregnant patients to be considered a very unique population. There's a risk in pregnancy developing either influenza viral infections or COVID-19 for hospitalization, mechanical ventilation, preterm birth, and an impact on the neonate. But I'm particularly concerned for women that begin pregnancy obese because they may be at a higher risk for these infections. So when we think about the public health messaging that pregnant patients have heard from the beginning of the pandemic, it has shifted many times from pregnant patients are not more at risk to they might be more at risk to we're really not sure. And I think that the evidence is more and more on the side that there's an increased risk for hospitalization in pregnancy, an increased risk for mechanical ventilation. And in many cases, we have seen that pregnant patients with COVID-19 are delivered specifically due to the way that their infection has compromised their pregnancy, resulting in a preterm birth. With our study, with an overrepresented prevalence of pre-pregnancy obesity in pregnant patients in Washington State compared to non-pregnant adults, we're concerned that obesity adds another layer to these risks.
Thank you. And please do keep your questions coming in the Q&A box, or if you do want to ask them orally, just let us know in the Q&A box as well. Maybe I have a question now for Malavika. So, I mean, we look at the risk factors for pregnant women, but I think you've highlighted that we have to continue to look after them after birth. And I think do you have any thoughts about how we should be approaching the postpartum period, and if there are anything we should be doing to monitor the infants of mothers who have had COVID during their pregnancy?
That's a great question. Here in New York City, we did recommend that all women with COVID-19, symptomatic or asymptomatic, in the context of being postpartum, which is at baseline a higher risk state for having a venous thromboembolic event or a blood clot, get started on prophylactic anticoagulation, meaning preventive blood thinners to prevent them from getting a blood clot, which we know the highest risk time is postpartum anyways, and extrapolating a little bit, A, from the fact that COVID-19 is associated with coagulopathy in non-pregnant individuals, and B, we did see these events of thromboses in the placenta. It did lead us to believe that there could be some increased risk. We have not seen any VTE events in our postpartum women with COVID-19, and that has not been reported in the literature, but even though it is a higher risk time, it is still overall, thankfully, a pretty rare outcome. So I think we need a lot more numbers in order to figure out whether ultimately women are having VTE events more frequently in the postpartum period. The other thing that we implemented was every other day telemedicine visits with women who were discharged with a recent diagnosis of COVID-19 through 14 days after their discharge. The idea being that A, we saw those increased risks of postpartum complications, B, at our institution as well as many other institutions, driven in part by the institution as well as the patient. Patients wanted to get discharged really early as long as they were healthy and their baby was healthy, which just led us to having an overall lower amount of in-hospital observation. And from a lot of the COVID-19 non-pregnant data, it seemed like there was some amount of biphasic presentation where patients would have some initial symptoms, seem to get better, and then ultimately have significant respiratory complications. And that was a little bit the story in the patients we saw who did have those postpartum complications that we reported. So given that, patients got a phone call every other day with a standardized script just to make sure that they didn't have any new pulmonary pathology, they didn't have any fevers, they didn't have any complications worth calling them in, because patients were very reticent to re-access healthcare, especially at the peak of the pandemic in New York City. And then lastly, for the infants, as I mentioned, we did not have any evidence of vertical transmission at our institution. That is still the case. I think we are all aware that there have been case reports of vertical transmission in the literature suggesting that it's possible, but maybe a low frequency event. But all of those neonates have been followed at 7 days of life, at 14 days of life, at 30 days of life for repeat SARS-CoV-2 testing, as well as overall clinical assessments by the Pediatric Infectious Diseases colleague. That evaluation has also been published actually. And overall, the vertical transmission, well, the horizontal transmission events to neonates was also quite low in that publication, but we do know that that is another source of acquisition, especially when infected mothers, potentially infected partners who we were not testing, are the primary caregivers for their neonates.
Thank you. And again, okay, so I have another question from Lola Herrero from Alpine in Spain. So this is a question for you, Malavika. During your research, did you find more premature deliveries in pregnant patients with COVID-19 than in pregnant women without COVID-19?
That's a great question. So the simple answer is no. The prematurity rate was the same across women with SARS-CoV-2 and women without. I think the more complex answer is really thinking about our study design, in which we enrolled women who presented for their delivery hospitalization, not women with symptomatic COVID-19 only. And a lot of the data on some increased risk of prematurity in the context of COVID-19 has been associated with severe illness, symptomatic COVID-19. And in our cohort, what we noted was that even though about 10% of all women did have COVID-19, 80% of them were asymptomatic. And really the vast majority of them did not report a known sick contact, someone with suspected COVID-19. Many women were actually quite surprised that they were SARS-CoV-2 positive at the time of their delivery hospitalization. So given the fact that they didn't have a severe infection or even a mildly symptomatic infection, it's not surprising to me that in our data, we didn't see any increased rates of prematurity. That's not to say that women with severe or symptomatic COVID-19 may not be at risk for prematurity, and there is a good amount of data, in fact, suggesting that.
Great, and maybe Kristina, do you want to add any more on from your experience? I mean, you noticed that the poor outcomes for obese pregnant women, but any other thoughts that you would like to add in around premature delivery risk factors in pregnant patients with COVID-19 from your cohort?
We have previously published a smaller number of patients from our cohort, which represented kind of our initial preliminary results just a few months into the pandemic when we had a smaller collaboration. And at that time, we published the results of a pregnant patient at 34 weeks who had been delivered preterm due to COVID-19, but also in the context of several other comorbid conditions. And so I think that the concern is women that begin pregnancy obese, but also have other comorbid conditions that also put them at risk for a preterm birth. Then we layer on top of this a moderate to severe COVID-19 infection. And then we have almost what we would consider kind of a perfect storm where there are multiple factors that are interacting at the same time that complicate the management of this pregnant patient and ultimately lead to the decision to deliver preterm. So these are the patients that we are most concerned about that may have had an increased risk for preterm birth initially, and then simply the decision process is kind of tipped in the favor of delivering, with COVID-19 playing a role in that. If we look globally, I believe that there have been several studies and data sets indicating that there's actually a lower risk of preterm birth globally, which is somewhat surprising to me and very different from what we see with influenza viral infections. But certainly for certain individuals, this is not the case where COVID-19 disease can, in fact, lead to preterm birth.
Great, thank you. And I have another question for you both, for Kristina and Malavika, again from Alpine. During your research with pregnant women, did you notice if they found more difficulties to access the antenatal services for them due to the impact of COVID?
I can take a stab at that first. That's a great question. So at least in New York City, the first case was officially reported on March 1st, although I think we all suspect COVID-19 was in New York sooner than that. And at our institution, by March 16th, a lot of changes had already occurred. And in that same week, we actually switched to doing a lot of prenatal care virtually or by video visit or telemedicine. So we risk stratified women based on their particular pregnancy indications as well as their gestational age to determine who would be a reasonable candidate for video visit versus in-person visits. And we were greatly able to decrease the number of in-person visits, which obviously had a lot of value for everybody, most notably patients, because just as Dr. Adams said, while the public health message about risks in pregnancy has varied over time, and especially in March, the message was, in the United States anyway, the pregnant women were at about the same risk and that there was no reason to think that they were at higher risk. Pregnant women themselves perceive themselves at much higher risk, and they did not want to be accessing care at our clinics, which were in the COVID hospital, so to speak. So given the fact that we were able to give women a telemedicine option, I would say many women preferred that option and actually continued to get routine prenatal care without any major interruptions in their care, and were willing to come in for the visits that we thought were truly critical to be done in person. There was a lot more self-monitoring of patients' blood pressures, patients' weight, patients' fetal status. But we actually saw very healthy pregnancy outcomes and associated with telemedicine, not any adverse outcomes. And this has been published in the literature from other New York City institutions, as well as institutions across the country. So I do think that one of the many positive learning points of this pandemic is that this is a very safe and reasonable approach to prenatal care in the right pregnant woman.
Kristina, would you like to add anything to that?
Sure, I certainly can. So in Washington State, we have kind of a combination of both urban and rural hospitals and clinics that participated in our collaborative. And we surveyed each of these hospitals and large clinic systems to determine when they began to institute universal screening for SARS-CoV-2 at the time of the delivery admission, and what were their strategies for testing and screening, and how this changed over time. And what we found were really significant regional differences in SARS-CoV-2 testing and when universal screening was implemented. But by June, nearly all of our hospitals and large clinic systems had already implemented universal screening at the time of delivery. But these different screening strategies also kind of were dependent also upon their access to testing. So while we had better access to testing in the Seattle area, this was not true in our with our rural partners. We implemented telemedicine very early at the University of Washington because we already had this system in place, and it was quick to credential providers in our University of Washington system. This did not happen with many of our rural partners. So there are many different changes that really depended upon clinic preference, access to testing, regional differences.
Thank you. And I think, Marco, do you have any reflections on this from the examples in Peru?
We have in Peru, with our health system, have three levels. The level 2 and level 3 have beds for these attend for this pregnant woman during the delivery, but these beds were enough, were not enough, or were enough. For that reason, in Peru, 15 years ago, 20 years old, in the primary care level, Peru implemented a little hospital to attend this woman. And more of the women now in Peru are attending in this primary care level hospital. But in the pandemic, in Peru, always in Peru was implemented too the universal screening at the moment of the delivery. But we had a problem because here in Peru we don't have the result of RT-PCR faster, and that is the reason why in Peru we apply some other tests. Yeah, you know the history in Peru, probably for the news that we were using the antibody test. But this creates a barrier for this pregnant woman, because at the moment of delivery they obtain a positive result. The primary level care hospital say, no, you can attend here. You need to move to the bigger hospital. But in the bigger hospital, all of the beds were busy, and that woman really had they need to look for a bed in this big hospital. And most of the time, they have some complication for this delay in the attention for the delivery. No? For that reason, in the primary care, implementing the universal screening for COVID in the antenatal or the prenatal, during the prenatal attention. That's if some of these women have a positive test previous to delivery, at the moment of the delivery, they present they present the result, and in the primary care level hospital, okay, you can attend here in the hospital. The healthcare worker lost the fear that for the COVID, obviously, in this form we increase the beds for increase the attention for this woman, because in the primary care level hospital, we have more beds than obviously that in the bigger hospital. That's what's that happened here in Peru.
Thank you, Marco. And I think that leads us very nicely onto sort of access and availability of the tests. And I mean, I think Jilian, it'd be great to hear about your thoughts on the work that FIND is doing with regards to access to both the screening tests and the diagnostics tests. And I think you've highlighted that the sort of the challenges that there might be, but how are we going to ensure access to them and what the future might be for these tests? So that and I think if you could just state as well for the audience to whether these tests are working as effectively in pregnant women and postpartum women as well, because that's sometimes an issue. Thank you. This will be our final question.
Great. Well, to the end of your question, I'm not aware of any research that's specifically been done looking at accuracy of some of the newer screening tests, so antigen tests in pregnant women, because we expect these tests to really be sensitive to the viral loads, unless we have an expectation that the viral disease course will really vary in pregnant women. And it sounds like perhaps they may even have more severe disease, which would perhaps be associated with higher viral loads, then we might expect these tests to perform very well in that context. Marco also mentioned the use of antibody tests, which are very widely available and are most appropriately now being used more for surveillance purposes or perhaps as adjunctive tests in addition to digital imaging, CT scans, and RT-PCR, which is the gold standard diagnostic. So in terms of access to the tests, I think the pandemic has shown us that by affecting every country on this globe, that our test manufacturers cannot possibly keep up with the demand for these tests. So we've really stretched the supply chain, and countries like Peru, for example, had very difficult times accessing RT-PCR tests in comparison to some of the higher income countries. So FIND and others are working very hard to try to make more tests available, especially in the global south. Not only gold standard RT-PCR tests, but also the antigen detection assays. And additionally, as new developments occur, such as perhaps innovations in sample collection, which might again increase access to testing, we'll have a clear focus on the global south. And I will say that currently most of the screening or diagnostic tests that detect the virus do still require a healthcare professional collecting a nasopharyngeal swab, which is also a very difficult thing to scale up widespread testing. So increasing availability of tests that are compatible with nasal swabs that could perhaps be done by a healthcare worker or by a patient themselves who's supervised by a healthcare worker might be something that should be coming relatively soon. And then perhaps more innovative sample types such as saliva or oral fluid may also be helpful to increase the ability for an individual to collect their own sample for testing, which will again increase access. Over to you, Grania.
Thank you very much. And I'm afraid to say that's all we have time for. But I'd like to thank all of our speakers for joining us today and sharing the results of their very interesting research, and for our media colleagues for joining to hear all about it. If you have any further questions, please approach Michael Kessler from the union's comms team if you'd like to follow up with any of our speakers today. So with that, I wish you a good rest of day and thank you very much.